Good afternoon. Сейчас появится. Good afternoon. Sorry, we are late a little bit. We had some technical problems, and maybe you can see the Russian lecture in this lecture room. And today is our last lecture according to acquired defects of maxillofacial area and principles of plastic and reconstructive surgery. Numerous classifications and nomenclatures exist in literature to describe maxillofacial defects. These classifications are not only useful for descriptive purpose but also provide guidance to the maxillofacial surgeon and the maxillofacial prosthodontists in reconstruction and rehabilitation phase. There remains, however, conclusion in use of terminology and nomenclature is there is no single classification which is accepted universally. Maxillofacial defects can be broadly classified into two categories. It's congenital and acquired defects. And a few words about what is congenital defects. Congenital anomalies can be defined as structural or functional anomalies that occur during intrauterine life, also called birth defects, congenital defects, or congenital malformations. These conditions develop prenatally and may be identified before or at birth or later in life. Congenital defects can occur anywhere in the body and can drastically affect the normal life of a person. Congenital defects most commonly occur because of two main reasons. Either when the mother during pregnancy is practicing pernicious habits like smoking, alcohol, and drug abuses, or during the developmental phase of the fetus some obstruction hampers the normal development of tissues. In later case, because of smoking, alcoholism and drug abuse, certain harmful substances cross the placental barrier and cause abnormal development of structures. One of the most interesting congenital defects that has been of a great concern and interest to maxillofacial surgeon and prosthodontist is occurrence of clefts. Clefts are basically developmental anomalies that are usually present in the midline of the face and drastically affect the normal anatomy. And according to the acquired defects, acquired deformity is a change in normal size or shape of the body part as a result of an injury, infection, for example, arthritis or some types of tumor, and usually it's, of course, malignant tumors. In the last 2 decades, treatment for head and neck cancer has involved with multiple modality treatments, including radiation and chemotherapy, in an effort to enhance local and regional disease control, reduce distant metastasis, preserve anatomic structures, and improve overall survival and quality of the life. Surgery is the first choice for early cancer and for cancers that don't respond to radiation or chemotherapy in form of salvage. Unfortunately, surgery can result in cosmetic, functional, and physiological impairment, greatly affecting the patient's quality of life. Any defect in maxillofacial region leads to loss of form, function, and aesthetics. It compromises the integrity of craniofacial region and thus poses a deeper impact of the individual, altering his personal and social acceptability to a major extent. Rehabilitation of these defects surgically or prosthodontically restores the function aesthetics to near normalcy and elevate the sense of incomplete to an extent but deep-seated insecurities and physiological impact need to be dealt with to ensure complete rehabilitation of patient and acceptance in society. Defects in the maxillofacial region may be intraoral, including maxillofacial defects or maxillary defects, mandibular defects affecting continuity of the mandible, and the last, it's a velopharyngeal defects or defects of soft palate and extraoral defect like residual ocular, auricular, orbital, cranial, nasal, or maybe combination defects. The various systems that classify as acquired maxillofacial defects are followed, and you can see it in this slide. And first, it's a classification, Aramani's classification for maxillectomy defects. And what is the reason of this maxillectomy? The reason or yes, the reason can be different. As I said, it can be usually tumors, it can be osteomyelitis, it can be some other traumas due to what we have to extract a part of the bone and usually the maxilla. And according to the defects of maxilla. Aramani presented a classification for maxillectomy defects and its classification from 1987. He divided the defects into 6 categories based upon the relationship between the defect with the abutment teeth. The classification is as follows. First class, and you can see it on this slide. It's a resection or where the resection is performed in the anterior midline of the maxilla with abutment teeth present on one side of the arch. Class 2, defect is unilateral, retaining the teeth of the contralateral side. Class 3, defect occurs in the central portion of the hard palate and may involve part of the soft palate, and you can see that the teeth are intact. Defect of class 4, it's a defect crosses the midline and involves both sides of the maxilla with abutment teeth present on one side, but it's bigger than class 1. And class 5, defect is bilateral and lies posterior to abutment teeth. Labial stabilization may be needed. And class 6, it's an anterior maxillary defect with abutment teeth present posterior to the defect on either side of the remaining of the maxilla. And let's see photos of patients with these types of defects, and you can see on this photo picture class 1 and class 3. Class 1, as you remember, it's a unilateral defect with one intact side and abutment teeth on this side. And class 3, it's a defect inside the hard palate and in sometimes soft palate too, but all teeth are intact. And this class 4 and the same class 3. Class 4, it's a defect crosses midline and involve both sides of the maxilla with abutment teeth present on both sides but posteriorly. This classification is devised in order to guide the prosthodontists in obturator design. It, however, lacks in description of the surgical defect. And next classification, it's a Spiro's classification of maxillary defects, and there are 3 types of maxillary defects: limited, subtotal, and total. Limited maxillectomy, it's understandable that any maxillectomy in which one of wall of the maxillar antrum is removed. Subtotal maxillectomy in which at least 2 walls of the antrum are removed, including the palatal wall. And total maxillectomy, it's a complete resection of the maxilla. The next classification, it's a Liverpool classification of maxillectomy defects, and it was described in 2006 thousands, and classified surgical defects separately according to the vertical and horizontal components of the defect. And on this slide you can see on upper side it's a vertical, and on lower side it's a horizontal. And you can see that vertical 6 classes and 4 classes for horizontal, and they are different by its numeration. You can see difference. Class 1 of vertical component, it's a maxillectomy with no oroantral fistula, or removal of alveolar bone that doesn't result in the oronasal or oroantral fistula, resection of ethmoidal sinus, frontal sinus, and maybe all lateral wall of the nose may also be included in this classification. Second class, it's a low maxillectomy. This resection involved the alveolus and the antral wall, which would inevitably cause oronasal or oroantral fistula. Orbital flow of the rim remains intact, and you can see it on the photo. Third class, high maxillectomy, and on this photo it's a third and fourth classes together. In this category, flow of the orbit with or without periorbital tissue is resected along with the rest of the maxilla. It may also include skull base resection, and it's third and fourth types, and fifth and sixth they can be gathered together. It's a radical maxillectomy or maxillectomy in the central part. And according to the horizontal component, letter A, it's a palatal defect only. Letter B, less than or equal to half of bilateral maxilla. C, less than or equal to half on unilateral maxilla. And on this slide they are changed. And letter D, it's a greater than half of the maxillectomy. Cantor and Curtis classification of mandibular defects, and here we'll talk about mandibular defects or defects of the lower jaw. And in 1971, Carter and Curtis gave a classification for mandibular defects. The classification is as follows, and you can see several types of mandibulectomy. First class, it's a radical alveolotomy with preservation of mandibular continuity. Second class, it's a lateral resection, and third class is a lateral resection too, but second class, it's a lateral resection of the mandible of distal side, and third class, it's a lateral resection of mandible to the midline. Fourth class, it's a lateral bone graft and surgical reconstruction. And fifth, the same, but anterior bone graft and surgical reconstruction. And sixth class, in sometimes we can divide this sixth class, it's anterior mandibular resection without surgical reconstruction. And on this slide you can see only 5 classes of this classification. And you can see that fourth and fifth class, it's with surgical reconstruction or bone grafting. About bone grafts, we'll talk later. Next classification of mandibular defects, it's a Juris classification, and you can see different types, and they are named by letters, and it's not difficult to understand. Letter C, let's start from C. It's a central defect of the mandible from canine to canine. Letter L, it's lateral defect extending from the midline to the condyle, and you can see that the condyle is safe. And letter H, it's a hemimandibular defect including L defects of the condyle. Here you can see different connection or combination between these main 3 types, H, L, and C defects. LC defects, it will be lateral with central part, and LCL, that means that 2 lateral defects of the mandible and central part, of course, too. And the last classification of mandibular defect by Erkin, this classification is based on functional consideration caused by detachment of different muscle groups and difficulties with cosmetic restoration. The classification is as follows. C, it's a condyle defect. R, it's a ramus defect. B, body. S, total symphysis, and SH, it's a hemisymphysis. And you can see it, I forgot to put these letters on pictures, but it's understandable. C, it's a condyle, like first letter of this word condyle, R, ramus, and you can see on upper side of this slide two different defects of right and left side. B, it's a body, and we can or we have to say about what part of the body or what side of the body of the mandible is with defect. And total symphysis or parasymphysis, or like central defect on Joer's classification. Face is the individuality of the person, and it's a medium of conveying various emotions, expressions, and governs the personality of individual. Based on age, gender, occupation, social interactions, and interpersonal relations, different individuals weigh their appearance differently. But as or a disfigured asymmetric face grabs first attention. Prior to involving the orofacial region, though affected by its integrity, is maintained. Post-maxillofacial surgery, the resected side leads to the loss of continuity and causes an altered, disfigured appearance. This is one of the major factors contributing to distress, shame, maybe, and psychological burden for the patient. Post-surgical depression hampers healing and makes patient prone to the infection. Surgical reconstruction or prosthodontic rehabilitation attempts to restore the function and aesthetics to as near natural as possible with its own limitations and constraints. The constraints include anatomical limitations which may limit the extension of the prosthesis material based on area of application, for example, intraoral or extraoral patient mental state and ability to accept. Acquired defect produce a deeper impact as individual is not born with the same and is affected later in the life, resulting in drastic change in appearance post-surgical or after prosthodontic intervention. They alter the integrity of craniofacial region, leading to disruption in normal functioning, maintenance of form, and aesthetic appearance of the individual, affecting overall psychological status of the patient. The condition might also alter the individual's financial, spiritual, and social status due to the irreversible loss, impaired social status due to the physical disfigurement, and mental impact. And surgical or prosthodontic modalities help in rehabilitation of the patient to bridge the gap and help to restore his individuality in the society. The whole process may manifest itself into various kinds of psychological impairment, including psychoneurotic, psychotic, or personality disorders, and the treating clinician must observe for clinical signs hinting towards this. This may include management. You can see on this slide different pictures before and after prosthodontic rehabilitation, and of course it's understandable that patients after cancer extraction need this rehabilitation, and it takes a lot of time in order to do these prosthetics and in order to live as they lived before this disease or before this grief. Prosthodontic rehabilitation allows replacement of lost structures with artificial substitutes to near normal appearance as possible. For extraoral defects, aesthetic is the main concern, and of course we as maxillofacial surgeons are interested in aesthetic or aesthetics after surgery, not less as for treatment of main disease. Various measures are taken to ensure correct anatomical alignment of artificial prosthesis, well adaptation, proper retention using retentive aids, including anatomical, mechanical, or physical means, and shape matching. Advancements in technology and introduction of three-dimensional scanning techniques using extraoral scanners, reconstruction or using DICOM image films, rapid prototyping and spectrophotometer have enhanced the precision that can be achieved in maxillofacial prosthetics. For intraoral defect, advancements in material leak peak, for example, and modification in designs allow to achieve more aesthetic result by concealing the metal display and enhancing appearances function. And let's talk about different ways how can we surgically and sometimes even without prosthetics help patients with acquired defects in the maxillofacial area. And of course, first of all, it's a surgical flaps, different types of flaps. And here I show you a slide with mnemonic flap moves to describe and classify a type of flap. And before it, let's talk about what is a flap. Skin flap is a type of wound closure. Local skin flap consists of skin taken from the adjacent area and moved to fill the surgical defect, often created from the removal of a skin lesion, such as a skin cancer, for example. Flaps differ from skin grafts in that the flaps is transformed with the intact blood supply and remain connected to its origin, while the graft is a transfer to of a tissue which has been completely removed from its origin, and therefore relies entirely on the recipient side for its blood supply. Classification of flaps is beginning was relatively easy, since they could be distinguished from one to another only according to how they were constructed. This included how they were transposed, for example, advancement, rotation, or transposition flap, their geometrical configuration are different, or by their destination. Because of their limited blood supply, there was a belief that random flaps had to be restricted to a right length or width ratio to ensure viability. Still, some flaps lived and others may die. And let's look on this slide. According to this mnemonic description or classification of different types of flaps, and you can see that F, it's a form or composition of flap. It can be skin flap, fascia, muscle, bone, or combination of these tissues, and I'll explain about it a little bit later, and I'll show you photos of these different flaps. Location. Local, they can be local, original, and distant. And of course, it's understandable that if they are local, it's not free flaps, and they're distant. Usually, it's a free flaps or free flaps, it's a grafts. Attachments. Free or pedicle. Perfusion, P. Random axial or no perforators. S, it's a special features, for example, tube, delayed, retrograde, superchanged, low. Oh, sorry, I forgot to remove it. And move, rotation, transposition, and advancement. And here you can see the definition of different types of flaps. And it's a classification of blood supply. How can we classify our flaps according to the blood supply? Random pattern or blood supply for these types of flaps come from many little unnamed vessels or capillaries. The majority of local skin flaps fall into this class. And axial blood supply comes from the recognized larger names artery or group of arteries. And usually it's a pedicle. Flaps and the pedicle is attachment of the blood supply to a flap. And here you can see different flaps with different blood supply of these flaps, and it can be random pattern flap, and we can see peripheral artery or capillaries, and you can see the depth of this flap where we can take it. Axial pattern flap, and we can understand that it can be a flap on a pedicle or it can be then when we'll cut this axial pattern artery, it will be a skin graft. And free flap, here it's a photo C or part C, you can see this bone graft. And perforated flaps. The next classification is according to the tissue type, based on the type of tissue that is being transferred. Skin, fascia, muscle, bone, visceral, or composite. And we can name these flaps by what tissue they involved. For example, if it's a skin and fascia, it will be fascia cutaneous. Skin, fat, and muscle will be myocutaneous. And the next classification, it's a donor site, or based on the site where the tissue flap has been taken from. And here you can see that they can be local and distant. What is local? It's a tissue transferred from the area next to the defect or recipient site. And they can be advancement flap. The flap slides directly into the defect from nearby. Rotation flap, semicircular flap that rotates above a pivot point into an adjacent defect. Transposition flap, the flap moves into the defect over the interradiant intact skin. And interpolation flap, the flap rotates about the pivot point into the nearby but not adjacent defect with the pedicle passing above the or below the skin bridge. And distant flap. Flaps, tissue transformed from a different part of the body from the recipient side. Pedicle, transferred while still attached to the original blood supply. And free flap, it's detached from the native blood supply and then reattached to a vessel at a recipient site. And this free flap, it's the same like a skin graft. And let me see. Next classification, according to the donor side, it's another big classification. The same we can say about local flaps, advancement flap, rotation, transposition, interpolation, distant, pedicle, and free. The same, but all in one. And what about local flaps? Local flaps can be divided into advancement flaps and transposition flaps according to the method of transfer. For covering mid-phase defects, the advancement flap and perforated base transposition flap are popular options. Both flaps are island flaps, and in terms of their shape, but the difference is the method of transfer. We are Advanced flap is a method which advanced V-shaped island flap to the different resulting of eagle shape as a final result. All otherwise perforator-based transposition flap is the method which rotates an island flap to defect with the pivot point of perforator pedicle. Both flaps provide advantages but also have drawbacks. The choice of flap to use often depends on surgeon's preference, which tends not to correspond to any systemic indication. An inappropriate choice of flap can result in acceptable outcome. And let's see on this scheme. It may be not so understandable, but then I'll show you photos of patients with these different types of flap. And according to the transposition flap, you can see that we have to do incisions of recipient side or next to the site of defect, and then we can transpose it or in some time rotate this flap in order to close the defect, and then we can suture all lines we've done. And here it's a case with a defect larger than 3 centimeter in diameter. And here you can see a 76 years old female patient with squamous cell carcinoma on the right cheek. And on first photo you can see this defect due to or after extraction of this squamous cell carcinoma. The size of defect after wide excision was near 3.5 and 3 centimeter. For designing perforator-based transposition flap, a perforator was marked, and you can see it with a red dot, and the length of the flap, and you can see it by a red arrow, and it was drawn on the skin, was determined by measuring the length from the distal edge of the defect to perforator marking. And you can see it by white arrow. The defect was covered with a perforator-based transposition flap. And on next photo you can see this transposition. We've done incision of this area and then transform or transfer this flap on the defect. And after it, suture all the lines of defect. The wound healed. It's the last photo without any complications, but midline unnatural contour was seen in the early postoperative period, and of course after it we can have some other types of reconstruction surgery and plastic surgery in order to remove all these signs of previous complications. Next case with a defect smaller than 3 centimeter in diameter, and it's an 82 years old female patient with basal cell carcinoma on the left nasolabial fold. The size of the defect, as I said, it was less than 3 centimeter, and defect was covered with the VY advancement flap, and we call it due to the shape of this flap. And the last photo you can see that the wound was healed without any complications, and everything is okay. And the next case, the same, smaller than 3 centimeter in diameter, and the same, it was a basal cell carcinoma near the nasolabial fold, and the same, we use transposition flap or perforator based flap, but here on the last photo you can see some complications while the process of the healing, and it was a trapdoor deformity on the flap margin was observed in an early postoperative period, and we can see superposition of this flap. and a little bit according to the rotation flaps. Most difficult and mathematically should be thought according to how can we form these flaps and how can we rotate. Rotation flaps are pivotal flaps with a curvilinear configuration. By necessity, they must be designed immediately adjacent to the defect. That the border of defect becomes the adjacent border of the skin flap. Although rotation flaps are useful in many clinical situations, the configuration creatures curved incision that frequently do not lie completely in a relaxed skin tangent lines. Like all pivotal flaps, rotation flap develops tendon cutaneous deformities at the base of the flap that cannot be easily removed without compromising the vascularity of the flap. Most rotation flaps have a random pattern blood supply. However, depending on the position of the base of the flap, they may on occasion be axial by incorporating the underlying fascia or muscle into the pedicle of the flap. Regardless of whether their blood supply is random or axial, rotation flaps are broad-based with favorable length-to-width ratio, and their vascularity tends to be reliable. Although rotation flaps are pivotal flaps in their movement, most are also advanced by stretching of the flaps. Depending on the degree of stretching, the vector of greatest wound closure tension may be along the line extending from the base to apex of the distal flap. When no advancement is used in movement of rotation flap, the greatest wound closure tension is perpendicular across the distal border of the flap, not across the long length of the flap. And here you can see on this slide different positions and incisions, how can we do and how can we rotate these flaps. Studies by Larrabee and God have demonstrated minimal benefit as a defect site of extending the arc of rotation flaps beyond 90 degree from the axis of the defect. This is to say wound closure tension is not reduced at the defect site by increasing the pivotal moment of the flap by more than 90 degree from the axis of the defect. However, there is often some benefit in extending the incision to accommodate regraping of the skin. Secondary defect created by rotation flap represents a transformation and translocation of the primary defect. The surface area encompasses by the primary defect is equivalent to the surface area of the secondary defect. The geometry of the secondary defect is determined by the size of the flap. The larger flap, and here I hope you understand that what are the differences between primary and secondary defect. Primary defect is a defect after our surgical extraction of, for example, cancer, and secondary defect, it's a defect or incision which we've done in order to rotate and first of all form and then rotate this flap in order to close primary defect. The larger flap, the longer and narrower is a secondary defect. The narrower with or the width of the secondary defect, the less in the tension required to close the wound, in the less is secondary movement of tissue adjacent to the donor site. Other way of stating this in the the length of the arc and thus the larger flaps, the less is the wound closure tension across the repair of the secondary defect. Rotation flap are best suited for repair of defects that are triangular. And here you can see a picture of the patient, the same with the cancer of the lip, because cancer it's a usual course when we have to use flaps in order to close this primary defect. And it's a triangle flaps. Design of the classic rotation flap is seen on the slide, and a standing cutaneous deformity will develop at the base of the flap. A burrowed triangle can be removed to facilitate repair of a donor site wound. A back cut at the base of the flap shifts the position of the pivotal point and changes the location of the standing cutaneous deformity. When the rotation flap is converted to a two-dimensional form, it appears as in this slide. You can see this photo. As can be seen in this slide, or in this illustration, a problem encountered with the rotation flap is the unequal length of a flap's border, labeled B in the drawing, and compared with the widths of the primary and secondary defects. And you can see it by label A. In the drawing. A common method of equalizing this discrepancy is to excise an equalizing borrow triangle at some point along the periphery of curviline incision. The triangle's base is equal in width to the base of the defect labeled C in the picture on the slide. And you can see it on this slide. As general rule in designing rotation flap on a face, the length of the flap should be 4 times the width of the base of the triangle defect. When this ratio is used, excision of equalizing burrow triangles is usually not required. And you can see it on this photo. The same, we can see triangle defects, and we can make this defect with the triangle, and then we can close it by different other types of triangle defects. And determine the base of the flap along with its pivotal point, and enables advancement of the flap toward the defect during wound closure. Advancement reduces wound closure tension and often necessitates a smaller flap with a length movement about its pivotal point, that when the flap's pedicle is not widely undermined and advanced. In addition to reducing the overall size of the flap, and determine limits of the development of the standing cutaneous deformity by advancing a portion of the deformity peripherally away from the flap's base. Increasing of the degree of undetermined of the flap without lengthening the border of the flap doesn't significantly decrease wound closure tension. Likewise, enlarging the flap beyond the length of 4 times the width of the defect doesn't significantly decrease wound closure tension. When the single flap is used for wound repair, the arc of the flap may be adjusted for a number of considerations. For instance, the arc of the flap may be shortened to maintain the incision along the inside hair-bearing tissue. The arc may be extended more than 4 times. And the width of the defect when the defect is located in areas of limited skin mobility. And of course, we can't use it in nasolabial fold usually. To avoid standing cutaneous deformity at the base of the rotation flap, used to repair defect, defect should ideally assume the configuration of inverted triangle. The triangle should have the height to weight proportion 2 and 1. In addition, the arc of rotation of the flap is to be a completely symmetric curve. The height of triangular defect should be as a half of from half to 1 times the radius of the curve of the flap. And you can see the radius and diameter of this rotation flap should be as a half and 1 to the defect. To create the ideal condition for use of rotation flap, the defect can be enlarged by removing normal tissue and converting the defect into a triangle with a height-to-weight ratio. There are several advantages of using rotation flaps, and the flap has only two sides. As a result, the surgeon can sometimes position the arced incision in a static border. The flap is broad-based and therefore its vascularity tends to reliable. There is a great flexibility in design and position of the flap. Design of inferiorly based rotation flap promotes lymphatic drainage and reduces flap congestion and edema. Similarly, arterial and venous disruption may be minimized and the sensory innervation may be maximized by appropriately position of the base of the flap. And now let's talk about skin grafts. And as I said, skin grafts, it's removing a part of tissue from its vascular supply and put them on the side of a recipient or side of donor where we can or we have to do this reconstructive surgery. And according to the skin grafts, they can be full thickness skin graft and split or partial thickness splint grafts. And what are the differences between them? Of course, it's understandable that full thickness skin grafts, it's skin grafts which contains or involve all layers of the skin of full thickness grafts, and split or partial thickness, it can be thin, moderate, and thick according to the thickness of these grafting tissues. Split thickness skin graft consists of epidermis and portion of dermis mostly, and thickness of the graft varies, and they are classified as thin, medium, or moderate and thick. Depending on amount of dermis included. Although less cosmetically appearing and less durable than full thickness skin graft, split thickness full graft are more versatile. They are more likely to survive under condition of vascular compromise and can be used to cover areas with limited vascular supply, such as periosteum, perichondrium, peritenon, and perineurum. They are easy to apply than full thickness skin graft and can be used for large defects. Including those that cannot be covered by flap or wound healed too slowly by secondary intention. Split thickness skin graft allows for early visualization of recurrent tumor and may be used to cover post-surgical defect at the risk for tumor recurrence. Preoperative consideration for taking a split thickness skin graft from a different anatomical site to close the defect include skin thickness at a donor site. It's the first. Elder patients have thinner skin, which can make taking a split thickness skin graft from a certain areas difficult or even unable. And second, it's a need for a skin graft versus primary closure. And on this slide, you can see the same different thickness or different forms of skin grafts. And this slide, on this slide, you can see a picture. How can we, one of the method, how can we take a skin graft from the patient healthy skin, and it's an arm or leg. Advantages to the skin grafts: a larger size skin graft can be taken into count for shrinkage of the skin graft and decreased need of the meshing. Thicker skin graft can also be harvested from the anatomical site, which thicker skin for better cosmetic outcomes. For example, better color retention and less contraction with the healing, and the reduced free flap donor site wound tension closure. Disadvantages include color and hair. Yes, I have it. Color and hair mismatch, increased morbidity from second donor site, for example, pain, infection, wound care, and cosmetic defect at the skin graft donor site. And fourth, it's a more wound care needed at the free flap site compared to primary closure. Harvesting the skin graft from the anatomical location can be easily complete, such as anterior or medial tight hip or buttocks. The need for assistance in the postoperative wound care can make the buttocks less advantageous. Special considerations for covering a free flap donor site include the underlying tissue and thickness of the skin graft. Some free flap donor sites are left with minimally vitalized structures such as the tendons, and thicker skin graft have high metabolic demands. Thicker skin graft placed over the tendons may result in a graft failure in those areas. Contact between the skin graft and the recipient site is essential, and I have a photo. Yes, here you can see primary defect after extraction of a tumor of this area, and after skin graft reposition of skin graft, and this skin graft from supraclavicular fossa. It's a full thickness skin graft. And on photo C, you can see a gauze bolster dressing secures graft in place, and usually not less than 5 days, in order to press this skin graft to the donor site. Bolsters also prevent sharing forces from the disrupting vascular connection between graft and the wound bed. And of course, it's understandable that disrupting this vascular supply of skin graft and wound bed will lead to the failure of this skin grafting. Systemic illnesses that may compromise graft survival include collagen vascular diseases, hematologic disorders, diabetes, nutritional deficiencies, and hyperexemia. Use of tobacco products is also determinant to the survival of the skin grafts. And here you can see the same, it's a skin graft, full thickness skin graft, and it's not so deep wound, and it's a wound after extraction or excision of the cancer of this area. For deeper wounds, skin grafting may be delayed until granulation tissue has filled the wound bed, and usually it's 2 or even 3 weeks. Any epithelium on the surface of the granulation tissue is removed before grafting, and the tissue is cross-hatched so that myofibrils are released. Granulation wound normally contains bacteria, and when delayed grafting is planned, the patient is prescribed 10-day course of antistaphylococcal antibiotics to begin 3 days before skin grafting. When necessary, wound culture specimens are obtained to direct antibiotic selection, if needed, of course. And the same basal cell carcinoma of auricle of the ear, and after resection, this patient needed for full thickness skin grafting, and you can see the results on the photo D, postoperative view. If you have questions, you may ask them in our chat. I'll try to read it. If everything is understandable, let's talk about bone grafting. Bone grafts are used as a filler and a scaffold to facilitate bone formation and promote wound healing. These grafts are bioresorbable and have no antigen-antibody reaction. These bone grafts act as a mineral reservoir which induce new bone formation. Rich defect develop as a result of surgery, trauma, infection, or congenital malformations. The goals of osseous replacement are maintenance of contour, elimination of dead space, and reduced postoperative infection, and thus enhance body and soft tissue healing. The insufficient quantity of bone is due to tooth loss, which results in a rapid resorption of alveolar bone due to a lack of intraosseous stimulation by periodontal ligament fibers. For example, pneumatization of maxillary sinus following tooth loss. And for example, due to generalized periodontitis. Easily, the patient can lose the teeth. Bone grafting is a surgical procedure that replaces missing bone with material from patient's own body, artificial, synthetic, or natural substitute. Bone grafting is possible because bone tissue has an ability to regenerate completely if provided the space into which it has to grow. As natural bone grows, it generally replaces the graft material completely, resulting in a full integrated region of new bone. And according to the classification, here, yes, you can see a classification of bone grafts. It can be allograft, based bone graft involved allograft bone, used alone or in combination with other materials. And for example, grafton or orthoblast, we can use these materials as allografts. Factors based on a graft are natural and recombinant growth factors. Used alone or in combination with other material. The same as transforming growth factor beta or TGF beta, platelet-derived growth factor, fibroblast growth factor, and bone morphogenetic protein. The next is a cell-based bone grafts. Use cells to generate new tissue along the or are added into on support matrix, for example, mesenchymal stem cells. Ceramic-based bone graft substitutes include calcium phosphate, calcium sulfate, and bioglass used alone or in combination. Polymer-based bone graft uses degradable and non-degradable polymers alone or in combination with other materials. For example, open porosity polylactic acid polymer. And a little bit about all of these bone grafts. And first, it's a biologic mechanism for bone grafting. The biologic mechanism that provide rationale for bone grafting are osteoconduction, osteoinduction, and osteogenesis. What are they? Osteoconduction occurs when bone graft materials served into the scaffold for new bone growth, which is perpetuated by the native bone. Osteoblasts form the margin of the defect that is being grafted, utilize the bone graft material as a framework upon which they spread and generate new bone. In the very last, a bone graft material should be osteoconductive. Osteoinduction involves stimulation of osteoprogenitor cells to differentiate into osteoblasts and then begin formation of a new bone. The most widely studied type of osteoinductive self-mediator are BMPs. A bone graft material that is osteoconductive and osteoinductive will not only serve as scaffold for currently excision osteoblast, but will also trigger formation of a new osteoblast, promoting faster integration of the graft. And sometimes in this mechanism we can talk about osteopromotion. But on this scheme there is no osteopromotion. Osteogenesis, it will be the last mechanism for this bone graft system. It occurs when vital osteoblast originates from the bone graft material, contributes to the growth of new bone along with the bone formation. And let's see examples of different bone grafts. And first, it's an autograft. Autologous or autogenous bone graft involves utilizing bone obtained from the same individual receiving the graft. Bone can be harvested from non-essential bones. Of course, we have no non-essential bones, but we can take it such from the iliac crest and even mandibular symphysis. It's a chin area usually, and anterior mandibular ramus or coronoid process. In some cases, we can use coronoid process for autografting. And on this photo or in this picture, you can see sorry, torus of mandible. It's enlargement of mandible side in order to reduce chewing pressure, and we can use it in order to replace this bone part into other bone or mandible or in the maxilla, or even for sinus lifting. Yes. All bones require blood supply in transplanted site. Depending on where the transplanted site is and size of the graft, an additional blood supply may be required. For these types of grafts, extraction of the part of the periosteum and accompanying blood vessels along the donor's bone is required, and we can do it too. This kind of graft is known as a free flap bone graft. Allografts. Allografts. Allograft is derived from humans. The difference is that allograft is harvested from the individual other than the one receiving the graft. Allograft bone is taken from cadavers, then have donated their bone so that it can be used for living people who are in need of it. It's typical source for a bone bank. The use of allografts for bone repair often requires sterilization and deactivation of proteins normally found in healthy bone. Contained in the extracellular matrix of the bone tissue are the full cocktail of bone growth factor, proteins, and other bioactive materials necessary for osteoinduction and successful bone healing. The desired factors and proteins are removed from the mineralized tissue by using a demineralization agent such as hydrochloric acid, for example. The mineral content of the bone is degraded and the osteoinductive agents remain in demineralized bone matrix, or DBM. On this slide, you can see next part of this classification. It's a systemic variance of bone grafting, and you can see different characteristics of these synthetic variants. And they are flexible, and usually it's a flexible hydrogel hydroapatite. It's a composite which has a mineral to organic matrix ratio approximating that of human bone. Artificial bone can be created from ceramics such as a calcium phosphate, bioglass, and the calcium sulfate as a biological active depending on solubility in physiological environment. These materials combine with growth factors, ions such as the strontium or mixed with the bone marrow appropriate to increase biological activity. The presence of elements such as the strontium can result in a higher bone mineral density and enhanced osteoblast proliferation. And here on this slide, you can see post-extraction ridge preservation. The root of the tooth was extracted and refilled with the bone, alveolar was refilled with the bone graft in order to save the level of the bone and maybe for next implanting of the tooth. Xenografts, a few words about xenograft. They are bone graft from a species other than human, such as a bovine, and are used as a calcified matrix. And according to the growth factors, in Russian Federation or in Crimea, it's not so widespread, maybe as in other countries, but you have known about it. Growth factors enhanced grafts are produced using recombinant DNA technology. They consist of either human growth factor of morphogens. It's a BMPs in conjunction with a carrier medium, such as a collagen, for example. The factors and proteins that exist in the bone are responsible for regulating cellular activity. Growth factors bind to receptors to cell surfaces and stimulate intracellular environment to act. Generally, this activity this activity translates to a protein kinase that induce a series of events resulting in transcription of messenger ribonucleic acid and ultimately into the formation of a protein to be used intracellularly or extracellularly. And on this slide, you can see photos of the patient with chronic generalized periodontitis, and we can see bone loss. And after professional cleaning and scanning and scaling, and removal of tartar and calculus above and beneath the gingival level, we can use surgical treatment of this pathology in order to prevent tooth loss. And we can use concentrated growth factor membrane. It's a special membrane which we can put on this uncovered bone and then suture it. And in the lower part of this slide, you can see outcomes or results of this treatment. Of course, it's excellent. On this slide, you can see other type of bone grafting, and you can see that we can put, for example, some special bone graft materials. Nevertheless, which one? It's a bone graft scaffold in the special area, and then suture above its gingival level, and we are waiting of osteoinduction, osteoconduction, and proliferation, and the bone level will be on its right anatomical position and side. Other type of bone grafts, we can use them in order not only to prevent tooth loss, we can use it due to some mandible and maxilla fractures, not of course only mandible and maxilla, of all bone fractures, and not only in the maxillofacial area. And here I show you a picture with such type of bone grafts, and of course we have connect together two broken parts of the bone, and between of them we can see bone grafting. And of course sinus lifting, when we have to add bone material between sinus floor and the alveolar part in order for following placement of implant. For today, that's all. I hope it was interesting and not so hard to understand. Uh, of course, plastic surgery is the most difficult part of surgical stomatology in the Russian Federation. In English literature or English-speaking countries, this classification is quite different, but nevertheless, there are plastic surgeons and maxillofacial surgeons, and I'll repeat that it's not so difficult, but if you read and if you see this lecture, I hope it will be understandable for you. Thanks for your attention and goodbye.